I'm Duckworth. I am a fire captain and paramedic EMS coordinator for the Ridgefield, Connecticut Fire Department, about an hour outside of New York City. And my specialty is in pre-hospital medicine and mission-critical communications. Came here to speak about patient transfer and patient handoff. And what first drew me to the interest in this aspect of mission-critical communications is that patient transfer is something that happens so often with subacute patients as well as with acute patients that I find that many times both pre-hospital providers and in-hospital staff build bad habits that are antithetical to what we would normally consider mission-critical communications. We don't even realize it. In the fire service, lives depend on mission-critical communications. When they fail, someone dies and it becomes a headline. Whereas in hospital, in medicine, if someone dies because of a failure of mission-critical communications, they become a statistic. We don't realize it's something that's even happened. And while there are lots of guidelines from virtually every health organization across the globe, the British Medical Association, World Health Organization, every aspect, every corner, it's still very difficult to pick out the real critical aspects, the things and the rules that we need to follow, the habits that we need to build so we know what to do, not just when it's convenient and it's easy and we first walk into the ED, but at 3 o'clock in the morning where there's a million other cases going on so that we're ready for true mission critical communications when the really bad trauma or the really bad cardiac patient comes in. And so many of the recommendations that they have are specific to medicine, but many of them are still drawn from other professions that use mission-critical communications. In other words, the nuclear submarine service, the aerospace industry, fire rescue, the military, law enforcement. And I feel that many of those other professions have really boiled down the essentials a little bit better than the recommendations that we sometimes find from our hospital organizations and our medical organizations. One of the things that we need to focus on is the ability to build a mental model. When we get information from a patient handoff, we want to build that mental model for all of the team members that are taking care of the patient so that we know what the priority is, what brought us to this point, what the patient's current state is, and what we need to do about it next. And the recommendations that we tend to find for both the senders of the information and the receivers of the information tend to be the same. And this applies whether you're giving a report, pre-hospital paramedic to ED physician, or you're an ED physician giving a report to the surgeon or anywhere down the line. The first is to make eye contact. Someone else can be very, very busy and trying to multitask, but when you make direct eye contact with them, you're saying to them, I'm waiting for you to be ready for communication with me. You're doing it in a polite, collegial way. And the same thing applies if you're receiving the information. Stop and make eye contact. The second thing is control the environment as best you can. Some of the recommendations say that we should have separate rooms, basically isolation chambers to make handoff, and that's something like that's not always practical, but we can control our environment to a degree. We can calm things down a bit, perhaps move to a side, close a door, do something to make it a little bit less distracting. For the sender, you want to make sure that your ABCs, your critical hands-on, is being taken care of. If there is something that you've brought the patient to the emergency department for a care that they can only receive there, you want to make sure that that priority is identified and handed over to the ED staff, the A&E staff, so that they know what the next thing is that they need to do immediately. But you still need to be making eye contact with the team leader, with the physician, so that they know they're going to gather the information to take care of the whole patient, not just perform one next critical procedure. Finally, you want to use a standardized reporting method. There are many of them out there, from MIST, AT-MIST, to SBAR, to a million other ones. In my mind, it doesn't matter what one you prefer, whatever works for your system, just something that's so that you're speaking the same language. And then finally, you want to supplement the information, all of the little details in the paperwork when you're handing over the information. Verbal report should just be those priorities. Supplementary paperwork follows up later. And then finally, when you're taking in the information, you still want to follow the same similar rules, but what you want to do is ask questions, make sure that you confirm your understanding as you go, and summarize. report back those bullet points, those priorities, to make sure that you're clear in your understanding, everyone on your team is clear, you're all sharing that mental model so you can all work together for the patient, and it's a check back, it's error correction. The people giving report hear your summary and say, yes, that's correct, that's the next priority that we also see, we concur, and now the patient can move on. And really, it's a way to make the whole ED experience more collegial, reduce errors, reduce adverse events, and increase patient satisfaction, because the patients aren't wondering, do they know what's going on here? Why am I being asked? Why is my mother being asked the same questions 10 times? We don't need to start from the beginning. We want to pick up the ball and keep moving downfield with it.